point waiting.
So I'll start. Hi, good morning everyone. So I'm going to be presenting a retrospective analysis of 15
We
cases
have 5 minutes.
of gasless vitrectomy with cutter-assisted ILM internal peeling, which I've called as the CAPE technique for macular hole repair. So we know idiopathic macular holes are complex vitro-macular interface disorders and a prevalence of 3.3 cases in every 1,000 individuals. Till date, we've been doing three things. We started off with PVD induction, which gave us a success of 50 to 60%. We went on to ILM peeling, which gave a success of around 80%. And then went to inverted ILM peeling, which has gone to 90%. And the two things that have stayed common is the post-op positioning and the gas tamponade. But the problem was, how do we reach 100% closure? We're still stuck at 90%. There is some failure rate that does happen. We did something different. So what we were doing is, conventionally we were using the cutter, we were using the steering the retina, and then we were peeling with the ILM forceps, and we were using the forceps to somehow cover the macular hole. So we're doing something different. So let me show you what we're doing. So we go ahead with a routine PVD reduction and a core vitrectomy.
Performing a 25 gauge vitrectomy, starting with a core vitrectomy followed by a posterior vitreous detachment and completing the vitrectomy up to the periphery. We perform a fluid gas exchange and inject brilliant blue dye for proper staining of the internal limiting membrane for up to 2 minutes. Using the Tami's ILM peeling forceps designed by Epsilon, we scrape the ILM and obtain a temporal flap to a sizable amount, and with the help of the 25 gauge cutter, we trim the excessive ILM. Now what follows next is the CAPE technique. Herein we use the flat base of the 25 gauge cutter system by Alcon, and we just gently plug the ILM into the macular hole, and voila, the macular hole is opposed. We don't need any
we're not using any long-acting gas tamponades. We've been just using air for the last 15-20 cases where we've done. So our results have been pretty astounding. So we've had the macular hole ranging from small to large and a median diameter of 968 microns. What was actually amazing was that the ELM and EZ restoration was noted in about 33%, and a post-operative visual acuity improvement was seen in 66.7%. And the best part was there was 100% macular hole closure. We were not using any tamponades and no gas position, no positioning post-operatively. These are some of our results. So if you see on the image on the left, you can see these large big macular holes, and on the image on the right, you can see a well-opposed macular hole with no post-op positioning or any mount. So in conclusion, the CAPE technique definitely demonstrates a significant promise as an advanced approach for treatment of large macular holes. The CAPE technique allowed us to achieve 100% lateral closure for macular holes more than 500 macrons, and the best part was we were not using any gas tamponade or any post-op positioning. Thank you.
So it was just you left the IFR.
Yes, sir. That's it. Yeah. Just to FG and we left it.
Okay.
What was the maximum hole size?
Yes, ma'am.
What was the maximum hole size?
1300 microns. 1300 microns.
1300 at the base.
Yes, ma'am.
And what about, like you said that 100%, so how many were the number N? What was your N?
Ma'am, 15 eyes. At this point, we're doing 15 eyes only.
15 eyes?
Yes, ma'am.
And you compared it? Was there a comparative study?
No, ma'am. We're doing it now.
So there's no p-value or no study as such?
No, NASA.
This is just a
first line case.
Like a pilot data?
Yes, ma'am.
But there's no actual statistics you've shown?
No, ma'am. None at this present. We're comparing it now with our older cases. And how much we have about, right now we have about 45 eyes in the other group.
You are not given comparative data?
No, ma'am,
and
not
you
yet.
not compared or, how will you clear the confounding factors? For example, the surgeon factor.
Ma'am, only one surgeon, so that's what was the one factor that was there. I am trying to compare it with my older data, my last 2 years, but I wanted to have some more cases in this data because that was the higher number. So the statistics was not falling in coherence.
So this was only 15 cases.
15 cases, sir.
These were only 15 cases.
Yes, last 15
And
cases.
a maximum size was 1700.
1300 microns, sir.
Maximum size.
Maximum size at this point.
And minimum?
Sir, 800.
800 to 1300.
Yes, sir.
Okay, good. Visual acuity results?
So we had, on Snellen's chart, the patient was on 660, we've gone up to 618 and 612.
That's good. Thank you.
Thank you, sir.
Now may I ask Mr. Advik Sharma?
Next, Ujjwal will ready. Huh? Are you presenting? Nobody? So we will just mark it with pen.
Okay, sir.
Yes,
If it's done. Okay.
and with a pencil
If they have come.
if they're present.
Yes.
Ma'am, where are you?
So
Jana. Prashant, your roommates.
oh, Pavan ke liye, sir.
स्टार्ट कर सकते हैं So
Yeah,
good morning everyone, I am Advik Sharma. I am presenting paper titled Awareness and Knowledge of Eye Donation in Patients Attending IOPD in a tertiary care hospital in North India. According to WHO, blindness is defined as a visual acuity of less than 3/60 or a notable loss of visual field in the better eye, even with the highest level of correction available. Corneal opacity is one of the top 5 causes of blindness globally. The causes of corneal blindness are ophthalmia neonatum, vitamin A deficiency, ocular trauma and trachoma among others. Corneal transplantation is the sole method available for restoring vision in individuals with corneal opacity. Every year, 1 lakh corneal transplantation are needed to be done to decrease the burden of corneal blindness in India. With an estimated 90% of global corneal blind people residing in the country, need for more transplantable tissues rising each year. Willingness of people to donate eyes depend on the awareness of eye donation and level of knowledge. Therefore, we conducted this study. Aims and objectives to assess the awareness and knowledge of eye donation in patients attending IOPD in a tertiary care hospital in North India. This was a cross-section study conducted in the Department of Ophthalmology, CMC Ludhiana. A total of 140 participants who were above or equal to 18 years of age were included in this study. They were asked to participate in a questionnaire after a written informed consent was taken. The questionnaire was divided into 2 sections. Section 1 included questions related to awareness of eye donation and Section 2 included questions related to knowledge of eye donation. At the end of the completion of the questionnaire, a printed awareness pamphlet was given. Coming on to the result and analysis, a total of 140 participants who were above or equal to 18 years of age were included. 81 were males and 59 were females. Majority of the participants were from the middle and elderly age group, and majority were below the level of intermediate or post high school diploma. 64.3% of the total participants had heard about eye donation. The primary sources of information were family member, relatives or friends, and mass media platforms such as radio and television. Awareness of eye donation was significantly associated with education. Therefore, aware individuals were mostly with middle school or higher level of education. Only 33% of the aware individuals personally knew someone who had donated their eyes. 33.3% of the aware individuals knew the correct time for donation, and 38.5% of the aware individuals had correct knowledge about who can donate their eyes. Although the majority of the participants had heard about eye donation, only 44.4% of them were willing to donate their eyes, with health workers and schools contributing only 14.4% each as information sources. Integrating eye donation awareness into community outreach and school health education is essential. Though the general awareness was relatively high, detailed knowledge about eye donation was inadequate. Palella et al. In Andhra Pradesh found 49.3% awareness of the ideal eye donation time, suggesting higher knowledge in South India than North India. In rural areas, for improving the awareness and knowledge about eye donation, the authorities should print pamphlets in the regional languages, and in the case of illiterate population, community-based awareness program should be conducted. This study demonstrated that though awareness of eye donation among patients attending a tertiary care hospital in North India is above average, substantial deficiencies persist in the knowledge and willingness to donate eyes. These findings underscore the need for community-based education and integration of eye donation counseling into healthcare to bridge knowledge gaps and enhance corneal tissue availability in India. This was the questionnaire that we used. Thank you.
So you you had a total of 130,
So 140 participants.
140 participants coming to the OPD.
Yes, sir.
Which OPD?
Sir, ma'am, departmental OPD, ma'am.
The ophthalmology
Yes,
OPD.
yes,
so
ma'am.
you only saw the awareness. Were there already existing posters in the OPD? Because all these are confounding factors. They may not have heard till they entered your OPD and then they saw a poster. So are you sure that they knew about it before they entered your OPD? Or, these are things like,
Yes,
how
ma'am.
do you select? How did you select?
So, ma'am.
What sampling did you do? How was the sample size calculated?
So, ma'am, we took sample size from a study which was conducted by Krishna et al. In rural population of India.
No, how did you calculate the sample size?
Ma'am, actually, it was done by a statistician.
Yeah, so this you took a sample size based on the incidence.
Based on the yes, ma'am.
Okay.
Based on the
Okay.
awareness level of 28%, ma'am.
And how did you do the sampling?
Ma'am, basically.
What type of sampling was this? Did you take every consecutive patient which came?
Yes, ma'am.
So then it's called convenience consecutive sampling. Okay, so
Ma'am, actually, we first of all took informed consent form from the patient, and then after that, every patient that was coming, we included in the study.
were these patients or also relatives?
Ma'am, these were the patients, ma'am.
Only patients.
Yes, ma'am.
Was there any difference between males and females? Because you've not mentioned that. Awareness between
level.
males and females.
So, ma'am, no, ma'am, that was not statistically significant.
So you should mention that. That is also significant to mention that males and females had the same level of awareness.
Yes, ma'am.
So you didn't take the accompanying persons or
No,
patient
no, sir.
attendants
No,
or
sir.
anything
No,
like
sir.
that?
No,
So
sir.
what was your follow-up action
S-
with this knowledge which you gained out of the sample which came to the OPD?
Yes, sir. So,
What did you do?
sir, if you basically, there were some conclusion that was made that there's an urgent need for community outreach program where we have to conduct some engaging activities so that the awareness of eye donation can be raised, and apart from that, the knowledge about eye donation, that when eyes can be donated, and apart from that, who can donate the eyes. There is an urgent need to take some steps so that the knowledge regarding this can be raised, because no doubt people are aware about awareness of eye donation, but still knowledge that who can donate and when can be donated, it is still lagging, sir.
Okay. So
Yes, sir.
even before you go to the community, you can probably do some activities within your campus or within your
Yes, sir.
department.
Yes, sir.
So,
So, sir, basically, like
because
after.
it's a multi-specialty medical college hospital,
Yes, sir.
so you can do some activities there itself.
Sir, when the patient was included in the study, right after filling the questionnaire, patient was given a printed pamphlet in the regional language, that is English, Hindi and Punjabi, so that the knowledge about eye donation can be transmitted to them. And apart from that, any question that they have, that was also answered on the spot, ma'am.
Okay, thank you.
Thank you.
May I call the next speaker? Mr. Ujjwal. Do we have a timer? Is there an attached timer for the presentations?
Timer is there. मीडिया वाला ग्रोवर नहीं है क्या? मीडिया वाला ग्रोवर नहीं है। ग्रोवर होगा तो फिर सब कुछ ठीक होगा। मीडिया पर ग्रोवर is
Sound नहीं है, sound नहीं है।
they do a good job. I don't know. Maybe that is there. नहीं मैम, वो ग्रोवर वालों का तो अपना ऑडियो विजुअल सेटअप है ना सारा, दे डू अ गुड जॉब.
Good morning. My name is Ujjwal Thakran. I'm a third year MBBS student from CMC Ludhiana, and my topic is TFM changes in post-operative cataract surgery patients. So, TFilm, as you know, is a thin layer, consists of 3 layers: lipid, aqueous, mucin. It's essential for vision quality, lubrication, protection, and wound healing. Disturbances in the layer can lead to dry eye syndrome, and dry eye syndrome can cause patient discomfort, reduced or fluctuating vision, or delayed recovery. The aim is to evaluate and compare the T-film changes before and after cataract surgery. Materials and methods. It was a prospective observational study which was conducted involving 70 as of 70 patients aged 40 to 80 years undergoing cataract surgery under the mobile eye service of CMC Ludhiana. Pre-op and post-operative T-film parameters were assessed at baseline, 2 weeks and 4 weeks. For that, we did Schirmer's test 2 and ocular surface disease index. Schirmer's test 2, this was to evaluate lacrimal gland function. This was the scale that we used: mild, moderate, severe. For ocular surface disease index questionnaire, this was the 12 questionnaire that we used, and this was the scale that we used. The result showed that total of 70 eyes of 70 patients were included in the study. Each eye was taken to be a single case. The majority of subjects were 60 to 69-year-old, followed by 70 to 80 years. Gender-wise, there was a male predominance, being 61%. Schirmer's test scored pre-op, it was 18.5. At 2 weeks, values dropped to 12.8. By 4 weeks, they showed a mild improvement to 15, with p-value of 0.001, which was all statistically significant. OSDI, while we look at the values here, pre-op it was 9.6. At 2 weeks, it increased to 22.13, and by 4 weeks, it was 17.7, which all had a significant p-value also. Now, when we look at phaco versus SICS, we observed 63 SICS and 7 phaco cases here. While looking at the outcomes based on Schirmer's, there was no statistically significant difference. But for OSDI values, both at 2 weeks and 4 weeks, SIC had a higher difference with a p-value of 0.005, which shows that symptoms are more persistent in this case. Incidence of dry eyes was finally seen at 90%. We used OSDI as assessment of the dry eye. In conclusion, cataract surgery consistently induces T-film disruption. It peaks at 2 weeks with partial recovery by 4 weeks. It causes significantly greater dry eye. SICS causes significantly greater dry eye than phaco. And proactive management such as pre-op screening, patient education, and post-op lubricant eye drops are essential for recovery.
So, I'll ask.
In your study, the tear film was more disturbed in the aged people.
In the SICS group.
As,
In the SICS group, it was more disruptive.
yes.
Yes, sir.
So, what was the reason for that?
That's because of the larger incision that we use in SES compared to phaco. It leads to higher amount of dry eye severity and higher recovery times compared to phaco in SICS. Yes. And we do mostly SICS because the rural patients in mobile eye services, by the time we have intervened, the cataracts are already hard. So we have to usually mostly do SICS only there rather than phaco.
These are cases done by a single surgeon.
No, ma'am.
So there is a comparative difference usually. Were these cases always covered by the conjunctiva, especially in SICS? Like,
Ma'am, there were no special complications.
no, so no. As I said, that after the SICS, the tunnel or the incision was taken, were they always post-operatively covered with the conjunctiva? Because what kind of a foreign body sensation the patients have? Do you know it? What do you suspect is the mechanism of these dry eyes? Can you give me 2 or 3 mechanisms why these patients develop dry eye post cataract surgery?
Yes, ma'am. Because when we do surgery, we can damage the glands, which can cause
Damage to the glands is
like,
what else could be the reason?
So, ma'am,
because in phaco also you got it, right?
The scleral incision that we take in SSCS is bit more than we use of phaco.
So
it takes
mechanism of the dry eye, because you're studying dry eye, right?
To the T film, when there's damage to the T film.
Tear film instability.
Instability.
That is one. Another.
Ma'am, drugs के reason से post op.
Doesn't SICS lead to more inflammation also than phaco?
Yes, ma'am.
What is the ocular surface? Is there a positive feedback loop with ocular surface and inflammation?
Ma'am, I'm sure.
Okay, thank you.
What all parameters did you see in tear film instability? For tear film instability?
Ma'am, we checked Schirmer's and ocular surface disease index to check for that. And we checked the values at pre-op, 2 weeks and 4 weeks.
No other parameters?
No, ma'am.
Okay, fine.
Because ma'am, for mobilized services, for the follow-ups, I had to go to like rural areas, and I was gonna do T-BERT. However, doing T-BERT in like regionally, it seemed to be difficult for me.
How did you arrive at the sample size?
Ma'am, there were studies done in India which were also done in rural size. They had similar sample size also, so I just looked at that one.
Okay, thank you.
Thank you. So we have Dr. Navreet.
Are there any other participants or speakers?
Cross-sectional study to diagnose dry eyes in diabetic patients of rural Punjab.
Are you a participant speaker? Your name? Yeah, please start.
Good morning everyone. So my topic is dry eye in diabetic patients of rural Punjab. It was an ICMR project. So diabetes, only 34% cases are recognized and just 14% are well controlled. And dry eye syndrome is the most common and underdiagnosed complication. So our aim is to diagnose the dry eye in diabetes patients of the rural Punjab, and objectives were to screen the population of undiagnosed cases of dry eye in diabetic and non-diabetics, and explore the correlation between diabetes mellitus and dry eyes. So it was a cross-section study. Community-based health camps were conducted, and there were 2 groups. Group 1 was diabetic and group 2 was non-diabetic, and sample size was 262. So firstly, community notification was given, and outreach camps were conducted in 7 different villages, and consent was taken. Participant registration based on the inclusion criteria was there, and RBS and dry eye testing and symptom assessment was done via Schirmer's test and OSTA screening, and HbA1c sampling was done, and stats analysis was done afterwards. And results was age was significantly associated with dry eye syndrome risk, and gender and diabetes duration was not associated with it. With the increasing age, there was increase in the risk of the dry eye syndrome, and whereas gender and duration had no significant value in it, and diabetes had more severe dry eye syndrome. In Schirmer's, there was severe dry eye syndrome of 42% of the diabetes, whereas 10% of the non-diabetics were there. Whereas in OSDI, there were severe dry eye syndrome of 80% diabetics, and non-diabetics there were only 45%. So in diabetics, there were reduced tear production, increased severity of the symptoms, and there were increased RBS. So average Schirmer value in diabetic was 6.3, whereas in non-diabetic was 11.1, and average OST score was 62.3 in diabetics and 40 in non-diabetics, and RBS was in diabetic it was 209, and in non-diabetic average was 115.4. So correlation of RBS with Schirmer's and OSDI, higher the blood sugar level was linked to the reduced production and worse eye dry eye symptoms among the diabetics. So correlation between HbA1c and Schirmer and OSDI was taken. It was not significant. So a routine examination and checkups rarely screen. Routine diabetic checkups rarely screen for dry eye syndrome and missing a major comorbidity. So simple low-cost tools, that is Schirmer and OSD, can be easily added to the rural camps. So it was our conclusion. Routine screening with the Shermer and OST can detect the hidden burden and early improvement of the comfort and prevention of the vision loss. Integrating dry eye assessment into diabetes management is a practical and urgent need of rural health programs. Thank you.
So, is there any seasonal variation in this? Have we studied that?
Sir, we have not studied any seasonal variation. We have not studied any seasonal variation in it.
But you may have the data for that. What season you conducted the camps and all.
It was summer season.
So you can find out any confounding factors accordingly. Also, did you do HbA1c for your study? Because in discussion, HbA1c for your study, did you do it?
Yes, ma'am.
How did you do it? Because it takes. Did you bring the samples?
Yeah, ma'am. We took sample from there and from our college. Then we did that.
Who bore the cost of those tests?
It was an ICMR project, so it was a fund from the government.
Was this part of your thesis? Was it your thesis?
No, ma'am.
Okay. Was it community based? You went to the community?
Yes, ma'am.
And did you, was there, like for example, which Shermers did you do was one of my questions. Which type 1? So it had reflex. Can you just give me the mechanism of dry eye and diabetics?
Yes, ma'am. Ma'am, corneal ma'am, because of the neuropathy also, blink rate is low, and in diabetes, inflammatory mediators are more. So tear film instability is there.
So, will it depend on the duration of diabetes and control of diabetes? Did you take the duration of diabetes as well?
Sir, yes, duration is not significant in my study.
Okay.
Yes, sir.
So,
But
any diabetic, even a recently diagnosed diabetic,
Sir, if RBS is more, then it was significant.
and type 1, type 2?
Sir, it was type 2 diabetics only.
So, you studied only type 2
Type 2
diabetics?
diabetics.
So
Thank
like sir said, if it is, even if it's not significant, it needs to be mentioned because that's important. That if it's not proportionate to the duration of diabetes, which we would expect it to be, right?
I haven't mentioned that.
Okay. How is it different from other studies? Because this is
Ma'am,
quite
because
established.
It is one of a kind कि rural में study कोई हुई नहीं है.
How did you maintain the cold chain? Like ma'am said, you've taken the samples from the desert.
Yes, ma'am. We had some box. We took that samples from the place we are conducting camps to the college. Thank you.
Give her the sheet also.
Good morning everyone. I am Prakhar Arora from CMC Ludhiana. My topic is to determine the prevalence of refractive errors in undergraduate students of Christian Medical College Ludhiana. Introduction. Refractive error is the term used to describe a condition when incident parallel light beams are unable to focus on the light sensitive layer of the retina. The following are the most common types of refractive errors: myopia, hypermetropia, astigmatism. Importance of detection of refractive errors. It is the most prevalent condition that affects people of all ages and is the second most common cause of avoidable visual impairment, accounting for 43% of all visual impairments globally. According to estimates from the WHO, 19 million young adults suffer from vision impairment. Undetected refractive problems can lead to ocular discomfort, attention deficit, avoidance of work, and the formation of a negative link between visual discomfort and educational activities. Therefore, we conducted a study to determine the prevalence of refractive errors in undergraduate students of CMC Ludhiana. My aim was to determine the prevalence of refractive errors, material and methods. This was a cross-sectional study conducted in the Department of Ophthalmology, Christian Medical College Ludhiana. A total of 300 undergraduate students were enrolled and studied over a period of 3 months. A detailed history and examination of each student was done. Diffraction was done for each student with visual acuity less than 6/6 and error correction was provided individually. Further, types of refractive errors were recorded and categorized according to the dioptric powers. Results and analysis. Among the 600 eyes examined, the prevalence of refractive errors was found in 369 eyes, accounting for 61.5%. The most common refractive error was compound myopic astigmatism, seen in 168 eyes. Among 76 male students and 224 female students, prevalence of refractive error was 60.5 and 61.8 respectively. The prevalence of refractive error was found to be the highest in the age group of 18 to 20 years. Compound myopic astigmatism was the most prevalent condition, affecting 119 female eyes compared to 49 male eyes. Similarly, simple myopia was observed in 113 female eyes versus 33 in males, and simple myopic astigmatism was seen in 36 female eyes compared to just 6 male eyes. Less frequent conditions such as hypermetropia and other astigmatisms displayed minimal gender variation. Notably, among the 231 eyes with no refractive error, female again outnumbered the male significantly. Compound myopic astigmatism was the most common, affecting 168 eyes, mainly among 18 to 20-year-olds and 21 to 23-year-olds. Simple myopia ranked second, impacting 146 eyes, with the highest prevalence in the 18 to 20 age group and under 18s. Simple myopic astigmatism was affected 42 eyes primarily in the 21 to 23 and 18 to 20 age ranges. Less frequent conditions include hypermetropia, while 231 eyes showed no refractive error, especially among 21 to 23-year-olds. Discussion. The age-wise analysis underscores the burden of refractive errors among younger individuals, particularly those aged 18 to 23 years. The age group exhibited the highest prevalence of compound myopic astigmatism, simple myopia, conditions often associated with extended near work such as reading, studying, and prolonged use of digital devices. The current study also highlighted the predominance of myopic conditions with compound myopic astigmatism observed in 28% and simple myopia in 24.3%. Interestingly, the prevalence of myopia and astigmatism in this age group aligns with the global trend of rising myopia in younger populations. The low occurrence of hypermetropic conditions is consistent with their lower prevalence in the general population. These conditions are less common. Their presence across diverse age groups emphasizes the importance of comprehensive eye examinations to identify less frequent but clinically significant refractive errors. Conclusion. The findings emphasize the significant burden of myopia and astigmatism among younger populations. These trends highlight the need for focused public health strategies, including awareness campaigns about risk factors, preventive measures, and the importance of regular eye checkups. However, more similar studies across diverse populations and settings are essential to provide a deeper understanding, identify underlying causes, and develop targeted interventions for effective management and prevention of refractive errors globally. These are my references. Thank you.
Thank you. Couple of things actually. Did females outnumber your subjects? You said female eyes had more refractive
So we
error.
included like BSc nursing and all the nursing staff also. So the females were in a higher number.
So out of the 600 eyes you are saying?
Yes, sir. The 224 were females and 76 were males.
So naturally the females will
Yes,
outnumber, no? And the other thing I just wanted to know was, what was the inter-eye correlation? Like, was there any difference between the refractive error between two eyes of
Yes.
the same person?
Yes, so there was difference. So we studied like
Did we
eyes,
study
not
those?
like students. Like
Did we
stu-
study that? No.
Yes, sir. So we studied like if there are 300 patients, it will be 600 eyes. We studied each eye individually for each refractive error.
No, but what sir means is, did you compare the right to the left and find that rights were always more than left?
Is there any
no, sir.
anisometropia or no?
No, so we did not.
You did not study, or you?
So we just analyzed which refractive error is present in each eye, not compared the right to the left one.
Would you do a follow-up of these?
We can.
Because,
We can.
No, but the reason you should tell the reason why sir is asking this, because one of my questions was, did you grade them according to the year of course?
Yeah,
And why are we asking
they are
the same
still in the
question?
growing age group, so they might be developing myopia or refractive error. So if you study them after say 2 years or 3 years, and were they all using correction?
Not everyone, sir, but majority of them, yes.
Have you taken any family history? Is there any relation with the family history?
No, sir, we did not take any family history.
And the incidence of high myopia or pathological myopia?
No, we just compared.
You didn't do fundus?
No, sir.
You may have the correction still also, but once you want to publish the paper, you need to write all those things, as sir has suggested. Also, how many people were prescribed new glasses?
Okay.
That is a very important point which sir has raised. You need to add that to your study.
So beyond what astigmatism did you take it as compound?
Ma'am,
Even 0.2,
Yes,
0.1, any amount?
any amount.
By what? By
Any amount.
by retinoscopy or automated?
Automated refractor.
So only automated was
Yes,
done
ma'am.
for these patients? No
Yes,
subjective
no.
testing was done?
Subjective testing was also done for each patient.
And these are only only BSc nursing or also
And
MBBS?
MBBS also, all undergraduates.
Did you classify them as per the year? Did first years have less and then fifth,
No,
the
ma'am.
final years have more?
Age or
because-
something?
And we classified according to the age because across they all had different age groups.
So why would it have been more interesting had you given us year-wise categorization? The reason why would it have been more interesting?
Yeah, I think instead of eyes, if you would have taken patients or subjects and categorized them according to the age, that might have given a more significance to the study.
Also, what would be the confounding factor in this study? A very significant confounding factors in today's medical students, which may be slightly less in the nursing student. And that is, I think, screen time.
Yes.
Because mostly medical students these days are moving with the iPad, at least in our college. I don't know about you all, but
I think it's everywhere.
so how much of extra screen time do they have in addition to studies? Do they study fully on the screen or on books? All these things might have some role. Thank you.
Anyway, I think thank you for your presentation. Is there anybody else in the hall who is a presenter?
Dr. Niharika, Dr. Samriti, Dr. Prabjot, Dr. Dipali Mittal, and Dr. Apurva. So they'll be marked absent. We can end the session.
I think so.